technical concerns. We'll try to fill this as we go. I'd like to, my name's Renee Bittoun, and I'd like to welcome Professor Garry Egger from Garry.
Australasian Society of Lifestyle Medicine and probably Southern Cross University, as I have connections with 3 universities.
Just before we start, I'd just like to tell you that I've known Garry for decades and decades. Too long, he says. And we go back to the sponge ad, for some of you who know that ad, in the 1970s, late 1970s, and the whole new was then innovative quit campaigns, and that's how far back I go with Garry. So that's 40 years. So long associations, then a bit of a break, and now back to working together on this particular project, which I think might really be interesting and encouraging for you to hear about. So Garry's going to start this presentation, and I'm going to add the smoking cessation component to it. So without further ado, Garry Egger.
Thanks, Renee. Could you, if you have any problems hearing or responding to this, and please respond and write questions if you've got them, could you make a point of it, because Liz Baxter is sitting at another computer and she'll hopefully be able to make any amends there, and we'll presumably have people coming in as we go along. I'm going to talk a little bit about a new approach to a new process for working with chronic disease management, and particularly smoking. And this is something I've been working on now for 6 or 7 years with the group that I'm involved in, which is the Australasian Society of Lifestyle Medicine. You can look that up under lifestylemedicine.org.au. I've just come back from our 11th annual conference, which was in New Zealand, and which is the first time that we've been the Australasian Society rather than the Australian Society of Lifestyle Medicine. And we work principally in chronic diseases and try and work out principles and processes for working with chronic diseases, in contrast to the infectious diseases that we've had all that for years and years. Now, if I'll slip through this first part relatively quickly, because I just wanted you to understand the context of where this comes from in lifestyle medicine. Lifestyle medicine is a form of health promotion and branch of medicine targeting prevention and management of lifestyle-related diseases, and it has evidence-based interventions that integrate improvements in nutrition, physical activity, stress management, social support, and environmental exposures. There is a global lifestyle medicine association now. There's about 35 countries that have lifestyle medicine associations. We were one of the first in Australia, going back to about 2006. The Americans and us were involved in this, in the initial Lifestyle Medicine Association movement. It's important to recognise that this is evidence-based. It's not integrative medicine. It's not natural medicine. It's just another adjunct form of conventional medicine, but looking more at the different procedures that are required for working with chronic diseases. There's 4 components of this, and there's no point in having an adjunct process for working in medicine if it's not different to conventional medicine. And the 4 components that do make it a little bit different are, first of all, the knowledge or the science. That's what's the lifestyle and environmental determinants of chronic disease. My background is in epidemiology and behavioural biology, so I'm particularly interested in what causes chronic diseases, and I won't go into this today, but we have about 15 different determinants. We don't call them causes, but we call them determinants of chronic disease. And they all interact with each other to wind up with the 10 or 12 major categories of chronic disease, including heart disease, cancers, respiratory diseases, and so on. The second thing is the art, or the skills, and that is, what are the skills or practices for changing unhealthy lifestyles and environments? And that involves not just normal one-to-one consulting, but, as we'll see in a moment, other forms of consulting that are different and novel ways of spending more time with patients and getting more material across. The tools or the materials are what tests, devices, equipment can be used to assist changes towards a healthy lifestyle or environment. And with the development of the internet, there's lots and lots of these, but we're not going to go into those. The thing that we're going to look at mainly is the procedures and the actions and we're going to look at one of those. What sequence of steps needs to be taken to establish a course of action to improve unhealthy lifestyles and environments? Now, the conventional process in the medical system has been to work in a one-to-one situation with one doctor and one patient. If you try and find the evidence for this as better than any other form of consultation, you won't find it. There just isn't the data to show that this is the best way to do it. We've just always done it like that. Of course, there are group processes that you're probably familiar with, particularly with smoking, where you've got an educator with a group, but that's not necessarily involving a doctor, whereas this new system of shared medical appointments involves a doctor. So it's individual medical consultations carried out sequentially with a number of patients, administered by a skilled facilitator, with others with similar concerns listening and contributing. The way we do it in Australia is that you can have a team of people working on this, but the two main components of that team are the doctor and the facilitator. You need a doctor because it's a medical appointment, a shared medical appointment, but that doctor is doing consulting, one-to-one consulting with patients. The difference is, in a shared medical appointment, there's 10 or 12 other people watching and contributing to that consultation. And there's a facilitator running it and running the time for that consultation. You can also involve a practice nurse if there's any need to take somebody out for a special consultation that might involve something confidential. And you can have a documenter, because what we do is record the consultation with the doctor as we go along, and that's done on the standard medical reporting forms. And that has to be done if you're going to use the MBS system for billing this whole process. A shared medical appointment is a bit like this. You can see here, this was one that we carried out in Burke in New South Wales. We've done quite a lot of these around Australia and New Zealand now. You have a doctor who's over here, and if I can get my pointer to go over there. No, I can't. Oh, yes, I can. The doctor here is doing a standard consultation. He'll do the consultation under the direction of the facilitator, who is generally a practice nurse, but can be a smoking educator or a smoking expert. It can be an exercise physiologist. It can be a nutritionist, depending on the topic that you're working with. This topic here happened to be diabetes. And so the facilitator was a practice nurse who was trained specially in the treatment of type 2 diabetes. The documenter down here, who was actually me on this occasion, was typing the stuff into the medical director. Now, you only need 1 or 2 sentences for that to be legal, but you do have to have some documentation of the process. The facilitator then says, well, okay, this guy over here is ideal to start off the consultation, and so we direct the doctor to this guy to start off with. If we went to this guy here, he might talk too much, and the doctor will never get a chance to get any other consultation in early in the piece. If we go to this guy over here, he might not talk at all, and therefore we have to move on to the next one, and we don't get anything out of that one. The whole process is involved on peer support, and everybody in this room is told at the start of the session. Initially, they have to sign a confidentiality agreement to say that they're not going to talk about this outside the group, but then they are told that they are advised that they can contribute to the doctor's consultation, but it should be through the facilitator. So if they want to ask a question, even though this guy here might be the patient that the doctor's talking to, they say, can I ask, they put their hand up and they say, can I ask a question, or can I say something there? Because sometimes this person here might know more about what this person is doing and the doctor than what they know, and so can contribute more to that consultation. So it's actually a shared medical consultation. The doctor comes in after an initial component, and I'll go through that in just a moment, and spends an hour with these patients, so that every patient, in this case 10 people, 2, 4, 6, 8, 10, I think, or maybe 12, but they get the minimal amount of time required to register under the MBS and to be able to use the MBS item numbers for that. Now, if you've got any questions about this, please type them in so that we can talk a little bit about it as we go along. Otherwise, I'll just continue assuming that you're up to date with the process. But I have to say that until you've seen this process in action, you don't really quite understand it. It's somewhere between an individual one-to-one consultation with a doctor and a group consultation, group education consultation, or group education session with a health promotion person or a specialist health person in a particular area, such as quitting smoking, for example, or managing smoking. The background to these SMAs, they began in the USA by a guy called Ed Nofsinger, who was wanted to get more time with his doctor, but also wanted to get support from other people who had similar problems to him. And this was one way of doing it. It then moved to the Netherlands, to Italy and Norway, and they found that patient compliance was increased enormously. You can reduce the doctor's time involved in this now from, if you've got 10 people, it might take normally 3 hours to deal with 10 people. You're now able to deal with that in 1 hour. And as you go around the group, you find that the problems that are dealt with initially don't have to be dealt with for the last patients or the last few patients, because they've already had their questions answered. You'll see people in these groups who come in with a list of things that they want to talk to the doctor about. Halfway through the group, they throw that away because those questions have been answered. And people say one of the great advantages of this is that you have questions answered that you want asked, but somebody else asks them for you. It was thought not to be possible in Australia, and we've fought a long battle with the MBS since 2013. And we trialled it under an RACGP grant with high patient and provider satisfaction. And that was done initially with diabetes, but we've now done it with diabetes, with weight control, with chronic pain, and we're also halfway through a trial with smoking management now. And I'll talk about smoking management rather than cessation, because we are the process experts. We develop even though I'm an epidemiologist in health, we develop the process to help you get across, or to help the experts in a particular area, in this case Renee Bittoun, to get across the information that she needs to get across to patients in a group basis with a doctor, not on a one-to-one basis or an educational basis. If you look up shared medical appointments in your any of your medical literature, you'll find that there's over 500 papers, probably 1,000 papers published now, showing increased patient satisfaction and improvements over one-to-one consults in a range of different areas. So you can do this in a number of different ways. A shared medical appointment is a generic way of doing it, and we often say that if you've seen one shared medical appointment, you've only seen one shared medical appointment, because there's lots of different ways of doing this. There are physical shared medical appointments, and these include a range of physical tests by the GP or the practice nurse in a breakout room. The next one that we're testing at the moment is programmed shared medical appointments, and this is where you combine a program over 6 or 8 sessions, or in this case, the one that we're testing with Renee is over 5 sessions, and that can be in weight loss, in smoking, in pain, restless babies, there's just about nothing that can't be done in a shared medical appointments. The third type, which we haven't done in Australia yet, but it's used widely in America, is drop-in group medical appointments. So this is just drop-ins where at 2 o'clock on a Wednesday afternoon, let's say, people can come along with a health problem and meet in a group and have their health problem dealt with in the group, with others contributing to that. The composition of the groups is either heterogeneous or homogeneous, and the heterogeneous ones can vary in gender, in age, in ailment, in patients with different types of chronic diseases with similar lifestyle causes, or the homogeneous groups are people with a similar ailment or background, for example, type 2 diabetes, or in your case, if you're interested in smoking or drug abuse, it would be people with similar sorts of problems in those areas. They don't have to be exactly similar, but somewhat similar. I'm going the wrong way again. So if you look at this on a scale, where a shared medical appointment fits is you've got clinical care or one-to-one consultation with a doctor and a patient at one end of the scale, and you've got the group education or 1 to X number of patients at the other end of the scale. That's one educator and 15 to 20 different patients. At the clinical level, that is the left-hand end of this scale, you get the medical involvement, but you don't get the educational involvement. At the other end, you get the educational involvement, but you don't get the medical involvement. So a shared medical appointment is where you have one doctor, one facilitator, and 6 to 12 patients, where they get both the educational component and the medical component of this. These are some of our articles. If you want to follow these up, They're in the Australian Journal of General Practice. Used to be an Australian family physician in the Australian literature, and you can look at how this works, how the shared medical appointments work in this process. Shared medical appointments are a bit like medical mowers, and Dr. Rob Lawson, who's the CEO of the British Society of Lifestyle Medicine, says a mower is Japanese for meeting for a common purpose. The term comes from social support groups in Okinawa. Keep going the wrong way. The best reasons for a shared medical appointment, and you can apply this to anything, and I'm suggesting that you do that if you're going to do it with quitting smoking. There is some training that's involved in learning how to run a shared medical appointment, but this can be done online now through ASLM, the Australasian Society of Lifestyle Medicine. The advantages for patients is they get peer support and they get more time with their doctor to be able to talk about this. For the providers, that is the doctor and the facilitator, it's enjoyable. And they all say 100% of them who we've used in this process say, I really love doing this because I'm not repeating myself. It's not boring. And also I can relax a bit because there's other people helping answer the questions. And there's a facilitator who's coordinating it all. And the advantages for the medical assistant is that it's cost efficient, despite the fact that the MBS hasn't accepted this, or it has accepted it now, but took a long time to accept it. And it reduces the waiting lists for doctors as well. The barriers, the suggested barriers are that you can't use Medicare item numbers. Well, this was the case when we started doing this in 2013, but we know now that you can use Medicare item numbers. Those of you who are familiar with that, you can use an item 23 for 10 patients provided they all get an average, or they all get 6 minutes, a minimum of 6 minutes. If you've got 10 patients in an hour, the first one might get 12 or 15 minutes and the last one only 2 or 3 minutes, but they effectively get an hour, and that's what we've been arguing with the MBS for many years. Second suggested barrier is that Australians are different to Americans and are much more reticent to open up in a group. Don't believe it. I can assure you, in the groups that we've done, they will talk about anything. And if you listen to people in a reception area, they talk about anything anyway. Once you've gained their trust, usually after the first session, that's not an issue. The issue is making sure that people don't go and talk about it after they come out of the group. We have a legal document. Well, it's a legally formed document. It's never been challenged. In America, they've had over 500,000 people through these processes, and they've never had litigation of anybody saying anything about anybody else in the group. So if it doesn't happen in America, they're the most litigious society in the world, it's not going to happen in Australia. There will be special attention from government because of concern of over-servicing. That has happened, but in fact it's quite the opposite. You get not under-servicing, but you get more efficient servicing because you've got more people in the room. And there will be problems attracting patients. We found when we started this that when you talk to patients about wanting to do something like a shared medical appointment, only 50% say, yes, I'd like to be involved in that. But once they've done it, we've found 98% actually want to continue doing it. And 100% of providers want to continue doing it because it's fun. Why 98% of patients like SMAs, they get extra time with their own doctor and their provider, and they get a more relaxed pace of care. They have questions answered they might not have thought to ask. They get support or information from and hearing experiences of others, and they form these little groups that then sometimes go out and have coffee together and meet together and become discussion groups together. They see the doctor or provider in a totally different light, more relaxed. They get greater self-management, education and attention to psychosocial issues. They have the doctor's full attention, which they don't often get when they're in a doctor's surgery because the doctor's typing notes into the computer. We insist that that doesn't happen. The documenter types in the notes, and that's usually the facilitator, not the doctor. So the doctor has full attention to the patient. And it provides an additional healthcare choice. There's another reference there, and there are lots of references at the end of this if you want to follow these up. Why 100% of providers like SMAs? Not having to repeat things over and over, getting assistance from facilitators and the allied health professional. You may have two. You may have a facilitator who's a practice nurse or someone like that, and you may also bring in somebody if it's a session on exercise, or if it's a session on nutrition, you bring in a nutritionist or an exercise physiologist who can act as an additional facilitator for that group. You get increased team involvement, you get greater productivity and efficiency, there's documentation support, and it's more relaxing and more fun. And this is a quote, it's very useful and a totally different approach to what we're used to. It's quite natural after you start doing it. And so having said that, and I don't think there's any questions that have come up. Liz, are there?
No.
No?
Okay.
So people are obviously sound asleep or are not interested in asking questions. So I'm going to hand over to Renee, who will talk a little bit about putting smoking cessation into a shared medical appointment environment, which just gives you another vehicle, if you like, for dealing with smoking cessation in groups. Renee?
Am I going to move up here?
You can do.
Share this is a bit, sorry, I have a bit of problem saying it.
Okay.
Sorry.
Put this down.
Okay, the idea of this presentation is just to follow on from what Garry said and see what we could do with a...
Get out here.
Sorry, we'll just swap chairs here. It's better to do that. Can we do that, Garry? Thank you. Yeah, sorry about that. This is our first attempt, as I said earlier, to present from the APSAD offices itself. That's much better. Thank you, Garry. Thank you. Okay, so I'm adapting this to smoking cessation isn't quite as onerous as it sounds, because we have lots of experience doing groups decades ago, and so we have a really good idea what is helpful and what's encouraging in doing groups, and so the format isn't too foreign, certainly not to me. I'm just trying to move
Forward with that.
forward, do I? I'm hoping it should do. Move forward. No.
Liz?
Liz, we've got a small can't move this forward thing. I know why not, but I can't move my slides along. If in doubt, you all know that we can blame the tobacco industry for any sabotage. If it doesn't work, it's their fault.
How weird.
It is weird.
It's worked up until then.
Yes. Oh,
there we go.
what did you do then?
I just clicked on
Dear.
there.
Okay, thank you.
Might have just been frozen.
Frozen. There we go. Right. So the basics of the program really is centering our presentations and our descriptions in those groups on the basics of nicotine addiction, and that's what we're really basing our whole program on, and the pharmacotherapies that are involved if required. In these pilots work on changing the lifestyle experiences of our smokers, the environmental experiences and how to manage those, and how to manage long-term changes in their health-related behaviour. The approach being learning together in these groups about managing smokers around you, managing long-term consequences of your environmental exposures, how that may affect family and friends and their social environment. And we use the tools, in our case, contrary to, say, in diabetes where you do blood sugar, we use the tool carbon monoxide meter for motivational encouragement and for reinforcement, as well as for clinical management. And I think that's something that we all know we use our carbon monoxide meters for, but in the case of our groups, these are really interesting and novel for our smokers. We have, in the case of the pilot, I'm just giving you a demonstration of something. We have, some of you might know, access to smoking rates almost, for some of you who may not know this, suburb by suburb now in Australia. So we know, for example, there are certain suburbs in New South Wales, I think it's Mount Druitt and Blacktown, that are in the top 5 of the worst smoking rates in Australia. And the Northern Beaches are in the top 5 of the best, the lowest smoking rates. So in case you didn't know, you can look this up. And we've got this in particular area. Garry's established and has a grant to provide this for a small group of practices to see how we go as a sort of a pilot program. The marks in red you can see, I hope, in front of you are just to show you it's really got a very high burden of local health diseases and preventable diseases. So I've managed to put a red ring around that just to show you this is quite a high prevalence of smoking in this particular PHN we're working with. So we were able to recruit, Garry was able to recruit 5 GP practices in that area. And it's fairly intensive preparation. There's no question that all of you know when we talk about smoking and cessation, most of the, unfortunately, most of our GPs think they know something about it, but they don't know a great deal. So we do intensive in-servicing with our doctors and the groups generally about who are going to manage this. That is the doctor, the facilitator, and other nursing and paramedical allied health who are involved in that GP practice. There's a lot of training. As you all know, it's quite intensive and they need to know quite a lot, especially about relapse prevention as well, and in the group sessions that we actually conduct as a follow-up. So those group sessions in this case, there are 5 of them. They're fairly well designed and determined sessions. So this isn't just an arbitrary group together once a week. This is fairly distinctly topic-based groups that they will attend. And of course, we help with development of signs and pamphlets and handouts. We want to make sure that the GP practice doesn't put off people, put off them by using the word quit all over everything, trying to avoid intimidating our smokers, encouraging them, we hope, to want to participate in this. So not just the GPs want to participate, of course we want the smokers to participate in this and to consent to being in it and see that there is a real advantage for them to be there without being intimidated about it. So one thing that we did straight up was to send out a questionnaire to our GP practices, the actual service providers, that is the GPs who are going to do this, the nursing staff and any facilitators. This was a questionnaire about what they knew about smoking, and the upshot, of course, for this was to show them how little they actually knew, which is, what do they know about the half-life of nicotine? How do they know how nicotine's metabolized? Does it matter who is in front of you in terms of how you metabolize nicotine? The answer is, of course, yes. And this was to show them how little they actually knew. So we gave them a whole day of training after that, and then put up the questionnaire again and showed them, yes, look how little you actually did know, and now look what you do know. We showed them how to use a carbon monoxide meter, the monitor itself, how to use it and follow up patients using it, so that the idea was that they could use it as not only a motivational tool, but actually a clinical tool to change or add medications. All of this is terribly important, and it's an essential part of what is part of these groups. This is actually and it hasn't come up here, a sort of a draft, an example of, of a little pamphlet or notice that would, a poster, thank you, Garry, a poster that's up in the doctors' rooms, just to show them a little bit about how they might like to manage their smoking. As you probably all are aware, we're trying to get away from the word quit, so as to not intimidate our smokers, how to manage your smoking better, come to a shared medical appointment. This is what a little bit about what we do, and we're trying to prime the receptionist so that the receptionist also knows a little bit about what happens at these things, so that everybody's on the same page, as it were. And this is just a sample of you know, a more caring approach, we hope, for the medical practice to put up a sign, a poster in their practice. So the doctor's roles are things like a fairly long consultation, really. This can either happen before or after or during the shared medical appointment, depending on how this is run. But really, the typical, I think you all know this, medical history. And then what we're hoping our GP practices will do is actually, once we have better knowledge of the patient and what they've attempted to do in the past, or have not attempted to do in the past, with managing their smoking, that they're sort of given a bit of a prescription, as it were. We've done this before too. Give the patient a prescription that looks a little bit like this, a bit of a model. Please come along to these sessions, sign Dr. whoever. So if it's in writing, you know, rather than say, would you like to come along? Here's a prescription for it. A bit proactive. Again, trying to get the GP to engage with the patient and come along next week, 10 o'clock on a Tuesday, for example. Come to these 5 sessions once a week, and I'll be there, and this is what we're going to be doing. And the idea is to make it a bit more, as I said, proactive, and again, with the doctors very much involved in this, in the GP practice. And the follow-up is a short consultation. So every time we ask the individual about their pharmacotherapy and the effects of adjust the pharmacotherapy if needed, if they're having it, and to troubleshoot any questions or concerns. So there's, as you probably know, quite a lot to do in follow-up, especially medication changes that they're currently concomitant medications that might need readjusting. You know, do I need to tell you clozapine might need to be changed, warfarin might need to be changed. There are things, medications that, and this is a very important role of the GP within it. And can it be done in a group? It definitely can, because there might be other patients that are on a medication that might and need changing. The ability to discuss this in a group is actually quite interesting for others who think they're the only ones, but also they don't know these effects. You know, some of you may know we talk about caffeine and alcohol and various other topics that are really important. The facilitator's role, for those who are interested in what they might be doing, they actually provide the education sessions, and I'll just show you what those topics are in a minute, and respond to sort of the generic question and answers about smoking and cessation. You may have noticed in one of Garry's slides earlier, there is a board at the back of that group, and on that board we actually openly record things like blood sugars in the case of, say, the diabetic patients, or weight in the case of obesity groups. Well, in our groups, we're doing carbon monoxide readings. So we're actually showing that and having that up on a notice board. So Fred last week got a carbon monoxide reading of X, and this week it's Y, we hope. And there's a change. And why is there's a change? And what happens? So people are aware that there are different readings, different products people are smoking, perhaps milder cigarettes if they think that's a better form. We all know it's not, but to show them the differences, or using NRT and smoking concomitantly. Everybody has an issue particularly about the safety of that, so we can debunk those myths in a group of people together so that they all know and maybe have had concerns about it, and we can discuss that as a group, and the facilitator can do that. So at every attendance, the time to first cigarette is also recorded. So some of you know it might be 5 minutes one time, and if a patient's on varenicline or Champix, as you know, it might be an hour later, the next session they come to. So we record this, and it's not that we expect everybody to go bravo, bravo, and clap their hands. What we want people to be aware of is the differences between patients, the different appropriate pharmacotherapies if needed, the changes in their behaviour, and why these things change. These are the actual sort of generic general population subjects that we have at these 5 sessions. They're once a week for 1 hour, and we talk about nicotine dependence or addiction. We want to do that right up front as the first session, simply because we want everybody to understand what that is and how it varies with people and what withdrawals are. Again, I don't need to tell you that. It's really helpful for our smokers to understand the variety or the range of addiction to nicotine, that it isn't none of this is a one-size-fits-all in the brain, and we show them pictures of the brain, and some of our participants just love that part of it. The second and question and answer. Second session is on the heart and how the heart recovers, because people ask, we CO test, why the CO test, what that's about, and how that implicates on the cardiovasculature. How does the lung recover is one session. Myths about all of these things, I'm sure you all know. Debunk myths about dead cilia, debunk myths about the coughing, why people cough. They don't know this, and information, again, I don't need to tell you, the more our smokers know, the better they do. There's good evidence for that. In fact, the more you know, the better they do. So all of this imparting information, good evidence to show that the more they know, the better they can manage their smoking. We talk about lung cancer, we talk about diet and quitting, some of the concerns about weight gain and how to avoid weight gain. And the last session is on relapse prevention and cues and cue conditioning and strategies to prevent relapse. So this is really very good to engage our smokers, and it really engages our GPs, because most of them will initially not know much about much of this, and fortunately are learning a lot as they go as well. This is just a bit of a messy example of a sheet or a board that would be up in a practice that shows you a little bit about what we might do. So you've got your carbon monoxide in, as you know, it should have been here in parts per million. So John's comes in with 15, and the next date, it's 2, and isn't that what and why? And what happened to John? What was his medication? We might put that up. What were the questions he asked? Not sure if there's, he's feeling tired all the time. Can we discuss why he's feeling tired all the time? The next one, Jenny's gone from 20 expired CO'd from 20 to 5. She's smoked, 30 minutes after she woke up. It's now 90 minutes. And so she's worried about putting on weight and constantly hungry. So we put people's concerns up on the whiteboard and try to cover those concerns today or next time. Try not to wait too long to, cover people's concerns. Why does somebody like Chris go from 35 to 21? His time to first cigarette has changed, but it might be he's got symptoms of withdrawal. Why would that be, and what we can do about that? So he's going well, but he's not going as well as John, and how do we explain this to our patients in a group setting? It is tricky, but it is really rewarding for all of them to see how that is done, and answers questions that a lot of people, again, as Garry said earlier, don't necessarily think about or may have been embarrassed about asking. I mean, there could be on that question, I'm constipated. Most people don't volunteer constipation as a symptom of withdrawal. They don't volunteer it. They're embarrassed about it. but it actually does come up and we do mention it and why this can happen. So there are lots of questions and answers going on in, within the room in these sort of discussion forums for our smokers. So this is a pilot. We have yet to have results. We hope to have some results by the end of the year. So I'll invite Garry back, who's now on a shorter chair.
We have a question here from Tanya.
Right.
Can you talk about MBS payments available for the facilitator and the practice nurse? Okay, there's a number of different ways of doing this. The way that we using MBS is an item 23, which is about $37.50 per patient for the doctor. There's a 10991 and a 10997. That is people who are bulk billing and also for the facilitator. When you put those three item numbers together, it turns out to be about $48.50 or $50, let's say $50 per patient. So in each group, you should be bringing in about $500 for the group, which is then shared between the doctor and the practice nurse or the facilitator. That is likely to change in the near future for a couple of reasons. One is we are testing just how much the team should get from one session, and we started off with $400 and that wasn't enough. The government is now trialling a capitation system, the healthcare homes model, where they're paying doctors and medical centres so much for looking after patients at different levels of care over a year process. And again, that doesn't seem to be enough. The trial is not going so well. We have found, though, because we're able to raise the money on this, because we're given funding to pay the centres to test this out, we've found that $500 per session is a pretty good way to do it. The centre's not going to make more money out of it than doing one-to-one consultations, but they're not going to lose money. And in fact, what they will do, and we're not allowed to say that they can become more efficient, because that means they'll make more money, but they do become more efficient in doing a shared medical appointment, because you're seeing 10 patients in an hour rather than 10 patients in 3 hours, and B, those patients, many of those patients won't need to come back for individual consultations. So we've found that the number of individual consultations in a year decreases quite dramatically for patients that do shared medical appointments. So you're saving costs over the long term for the government. I hope that answers that question. It is going to get easier. We've put in an application to the medical benefits scheme inquiry for a special item number for shared medical appointments, and it turns out to be about $50 per patient per session.
Thank you, Garry. Can we just talk a little bit about sort of the I guess the acceptability of the smoking cessation, how it's been going? Yeah,
the important thing is, with smoking in comparison with something like diabetes or weight control, when you advertise for a weight control group, you get more than you can handle. You get oversubscription of the numbers who want to come along. With smoking, you don't. It's really hard to get the numbers, and we've found in the process so far that if we get 10 or 15 who are interested in coming along, you might get 8 or 10 turn up. Yeah. And then you'll lose 2 of those along the process. Yeah. We're trying to increase their ability to stick in the program, as well as the success of the program. We'll do that now by the next step, by changing the program, updating it, making it a bit more efficient than what it is. Mm. But when you test with the providers, that is the doctors and the nurses, what they think about the program, 100%. They love it, because it's a way of dealing with smoking that they just haven't been able to deal with before.
Which is really encouraging to know, isn't it, that they love it and they feel empowered or equipped to manage something that they haven't really had a lot of success with, I'd say.
Yeah, and one of the reasons for that is when you've got 2 people doing the whole process, and you've got another 10 who are patients there who know a lot about this, because they've tried it so often. You know, the best people to talk about quitting smoking are people who have tried several times and missed. So the doctor often quotes that they, or often say that they feel more relaxed in this consultation than they've ever felt in a consultation before. The facilitator, if the facilitator is boned up on a lot of the information, that facilitator can help the doctor. And the process is, if the doctor's stuck or there's something more to be added, we train the facilitators to go through the doctor, say, look, I know a bit about this. Do you mind if I answer that question? And then another patient might say, oh, I did that. Do you mind if I talk about this? And so everybody's helping everybody else. And that's why peer support is one of the most powerful behaviour change techniques that you can use. And that's done formally in this type of process.
I guess one thing I wanted to say was because there's so much mythology about smoking and treatments and managing it, do you think it's a bit curious that we do have patients who do really poorly because they propagate these myths and people get around these urban myths. Do you think learning on the part of the patient in this way, debunking myths, which is part of what we're trying to do with this?
Yeah, I think so. And also the fact that you've got patients hearing from other patients. So what they've experienced is not unique because other patients have done that as well. I'll talk just very briefly about a group that we did in weight control. This is not particularly related to smoking, but gives you an example. We had one patient in a group on the north coast of New South Wales who was not able to sleep. This was a diabetes group, and was still gaining weight and unable to control their blood sugars. One of the other patients in the room said, I think I know the answer to that. I had this happen to me. What do you drink during the course of the day? And the patient answered that she drank, I think it was 8 large bottles of Coca-Cola, full-strength Coca-Cola. And he said, well, there's your answer. That's sugar. So you're getting all the sugar in there, and it's caffeine, so you're unable to sleep because of that caffeine. And the doctor said in the group, he said, you never told me that you drank that much Coca-Cola. And she said, you never asked me. Because there's not time for the doctor to go through all of those sorts of problems. So that comes up in this group situation. This is a process that there's no doubt in my mind that in the next 10 years, every medical centre in Australia will be doing this in different forms. We're just trying to facilitate it by providing the program for them to do it. And hopefully by the end of this year, we'll have a program for smoking which can go out to any medical centre or anybody who wants to use it like that. There will obviously be involved some form of training for the doctor and the facilitator. That will always remain, but the package will be there that any centre can use.
Ironically, when doctors prescribe smoking cessation pharmacotherapies, implicit in the prescription is counselling. There is no counselling in general. There is no, except, here, put the patch on there. That's what's called counselling. There is really almost nothing that GPs feel comfortable or experienced with or educated in that they can actually provide or send somebody to, especially in areas where there is nowhere to go. So this is a really good way of getting a GP feel more comfortable about writing a prescription that is meant to be implied in that.
There's also a form of triaging that we use in some of these groups. We haven't talked about it yet with smoking, but with the weight control, for example, the bottom level of triage is behaviour change and education. The middle level is medical intervention and psychological intervention. So that involves prescription drugs and psychological care. And then the top level of the triage is surgery. So if you've got very big people who require a lot of treatment, then they do the bottom two, but they also have the surgery at the top. Now, I think we can probably do the same for smoking. There's people who've tried various things and haven't worked, and there's different levels of intensity that you can use at those different stages. So triaging is a very important process in lifestyle medicine. We actually do it, and we're developing a form of telephone triaging now before people come into the centres. They ring up the doctor, they ring up the centre, they talk to maybe a practice nurse to start off with, and then that person will decide whether the patient just needs a prescription or needs to do something or go away and lie down, or it goes on to an exercise physiologist, another allied health professional, or at the end process to the doctor. So the doctors are dealing then with the extreme cases, not all the piddly little cases that they get to waste their time on largely because other people can do it during the course of the consultation.
Liz, do we have any more questions? One more question coming up. Thank you. Well, this is all very interesting, isn't it? And it's novel for me to come back to when we abandoned groups decades ago now, because we did do groups and group education, but then our patients became so difficult to treat with, so much, they don't call it comorbidity anymore, they call it multi-morbidity. There was so much complexity about a patient, but now coming back to it again, which is very interesting for me, and looking at it a new way of approaching this.
Says, Renee, do you share your education program's 5 sessions that is delivered to this group for others to use? Well, we will once it's evaluated properly.
Yes.
And
so
we're in the process of doing that.
The answer is yes, but we're tweaking it.
Watch this space.
Watch this space. So, and thank you all very much for listening in today. I would like to just wrap up by letting you know that our next presentation on the 30th of July, so that's a month away, which is always a Tuesday, last Tuesday of the month at midday, will be our a pharmacist presenting from, some of you may know, Deepali Gupta from Queensland. Deepali is going to talk about pharmacotherapies and the myths, the complicated myths around cardiovascular effects of pharmacotherapies for smoking cessation. There is so much mythology out there. Cardiologists in particular have concerns that we want to debunk some myths about that, and Deepali will present on that. Does NRT cause coronary artery disease? Is varenicline safe with coronary artery disease? These are the sort of questions that are going to be answered next time. So 30th of July, we'll send you around an invite, and we'll see you then. So thank you, everybody. And thank you very much, Garry, for presenting today. It was great. Thank you. Goodbye, everybody.